Welcome everyone. Thank you for joining us in today's panel webinar, COVID-19, Stress and the Mental Health Pandemic. My name is Yusha Benjeloun, Administrative Coordinator and Project Manager with the Work Wellness Institute, and I'll be moderating today's webinar. We would like to thank our academic team and our 9 founding partner organizations in the Harnessing Talent project. Harnessing Talent, Alliance for Recruiting and Retaining Canadians with Disabilities and Mental Health Challenges, is a 3-year project funded by Employment and Social Development Canada. This webinar is made possible through the support of ESDC as well as memberships to WWI. We thank our advisory committee and speakers who contribute to this webinar series. To members, WWI, VRA Canada, or CPHR Alberta members, a reminder that you receive free certificates of attendance. Today, we're excited to have Dr. Roger McIntyre with us online. Dr. Roger McIntyre holds numerous prestigious appointments, so I will only cite a few. Dr. McIntyre is currently a professor of psychiatry and pharmacology at the University of Toronto and head of the Mood Disorders Psychopharmacology Unit at the University Health Network. He's also the executive director of the Brain and Cognition Discovery Foundation in Toronto. Dr. McIntyre is the director as well as co-chair of the Scientific Advisory Board of the Depression and Bipolar Support Alliance from Chicago, Illinois in the United States, clinical professor at the State University of New York, Sunny State Medical University in Syracuse, and clinical professor at the Department of Psychiatry and Neuroscience at the University of California School of Medicine in Riverside. Dr. McIntyre is the founder of the Canadian Rapid Treatment Center of Excellence. He was named by Clarivate Analytics each year from 2014 to 2020 as one of the world's most influential scientific minds, and he has published more than 700 articles and manuscripts. Dr. McIntyre's work broadly aims to characterize the underlying causes of cognitive impairment in individuals with mood disorders and their impact on workplace functioning. To know more about Dr. McIntyre, please visit our website at workwellnessinstitute.org. Dr. McIntyre, welcome. We're looking forward to listening to you. I will hand you the mic without further wait.
Well, thank you. Thanks for introducing me. Thanks for inviting me and giving me this opportunity to meet with colleagues, albeit virtually. We look forward to the days where we're back in person again, but glad we have this interface to share information. As it relates to this topic, which I don't think anyone needs to be convinced is a critical issue facing Canadians, and not just Canadians, but frankly, people all around the world, that being mental health in the time of COVID-19. COVID-19 has been presented as a public health crisis, which it certainly is, but I would expand it into what I call a triple threat. Not only is this a public health crisis, but it's also an economic crisis for many, many people, as well as a mental health crisis. And emanating and surrounding this entire time, the last 13, almost 14 months now and counting, is not just chronic stress, but really is the message of this talk, and that is it's chronic unpredictable stress. Chronic unpredictable stress, CUS. And we've learned from research at my center and many centers around the world that conduct this type of research that chronic unpredictable stress is worse than chronic stress and has the most malignant effect on your physical health and mental health. So far, doesn't sound good. But a positive is that this is not a scenario that we need to accept. There's lots of evidence now that would indicate there's aspects that we can do that could be mitigating and be wellness enhancing. And I'm going to speak to a couple of those concepts during this very brief presentation. So we'll get started and as we go through. Now what I want to do, and I recognize that people joining the call today come from different backgrounds, and that's the richness of this type of format with the Wellness Institute. People have different roles and responsibilities, and frankly have different funds of knowledge as it relates to mental health or mental illness. So with that in mind, I will just start off by saying, look, nobody needs to be convinced that this is a chronic, unpredictable, stressful time. my message is that the rates of mental illness have gone up. And you're not surprised to hear that based on, or simply by paying attention to media, which has been covering this. And recently our group in Toronto has attempted to synthesize the world's literature on the topic. And if I was going to be just very brief, and I'll keep it nice and digestible, is that the rates of select mental disorders have been increasing, such as major depressive disorder, some anxiety disorders, PTSD, which is a stress-related disorder, insomnia, which is overlapping but different, alcohol and drug use disorders, as well as eating disorders. Those have all been on the uptick. And what we're also hearing is that calls to emergency centers, 24-hour crisis lines have been on the uptick. So there's a general level of distress. But as often the case when it comes to risk, the risk is not equally distributed. And this was something that came out of our work, where we identified select subgroups in our population that are more at risk. You've heard so much about racial and ethnic minorities being at greater risk of COVID complication, all true. They're also more at risk of mental health complications. To keep going with that, that is looking at this through the lens of pluralization and the plurality of this, women seem to be at greater risk than men. And what's interesting is that younger populations are at greater risk. And that's an important point for distinction, because until the variants came along, we had understood that older people were at greater risk of contracting COVID-19, and that's true. But younger people are at greater risk of experiencing mental health difficulties. And I'm going to be very generous today and say younger people means anyone under 30. And where things get particularly interesting is it's young women, especially young women with kids at home, and or young women who are having kids at home and they're on their own. That's a particularly concerning situation for many, not having the support, etc. So we are certainly seeing this happening, and this is now happening not just in high-income countries, but it's happening in low-income countries and middle-income countries. And I think that before we even get to full-blown mental illness, there is in fact another pandemic. I think people are feeling very lethargic, very tired. I think people feel fatigued, and a lot of brain fog out there, quite frankly. A lot of course, the word that's got most attention the last 3 months has been languishing. People have been languishing. They're not well, but they're not really flourishing. And this has been played out in different writings over the last few months. And it's true. It is exactly the case that people are reporting this, and there's a variety of reasons this is the case. So along with having an elevated risk of not just distress in the general population, but also rates of mental illness, it's also the case that if you have a mental illness, you are at greater risk of contracting COVID-19, being in hospital because of COVID-19, in other words, a more severe manifestation of COVID-19, and also having further complication requiring intubation as well as death. So you've heard a lot about pre-existing conditions like obesity and diabetes known to adversely affect wellness as putting you at risk of COVID infection and complication. Well, the same would hold true, in fact, for mental illness, such as major depressive disorder, bipolar disorder, ADHD, and schizophrenia. Now, one way to also think about what's happening is that across Canada and around the world, it has been amply documented that about 1 in 5 people will experience a mental illness at some time in their lives, 1 in 5. So if we take that as the prelude to COVID-19, there's a significant number of people who already had a pre-existing mental illness like depression. Well, we did a study in Asia. There's been other studies that have looked at people with pre-existing depression or anxiety conditions and so on. And maybe it won't surprise you, but we found that these persons were especially at risk of decompensation. So to summarize that, we have really three different ways we talk about this. Distress has been up, we all know that. Rates of mental illness have gone up, especially in some groups. And people who have mental illness pre-existing are at risk of decompensation during this COVID-19 time. The second comment around that is that people who have pre-existing conditions are also at higher risk of contracting and having complications from COVID-19. I think what's been laid bare by COVID-19 is not just the lack of equity in healthcare and access and utilization and all of that, but has also exacerbated some of the lack of equity in the system, broadly social determinants. It's exacerbated the hazards of economic insecurity, housing and food insecurity, the inability to access in timely way high quality, coordinated, accountable health care. That's also been an issue. And so this has really been a lesson on social determinants. We're often told that your zip code means more for your health than does your gene code, which is probably true. And the zip code implications have never been more apparent than they have been in COVID-19. So we can just keep going here. What I'd like to do now, if I can, is just maybe speak to some of the aspects around this. The first is that we have a significant increase in the prescription of select psychiatric medications during the past 1 year. It might not surprise you that the prescription for medications for sleep or anxiety and depression have in fact significantly risen. Now, we're here today to talk about wellness and workplace and function, but I wanted to let you know something that many might know, many might not know, and that is that the medications that we give people to help their depression is really a class of drugs that not only treat depression, but treat the biology of depression. And more specifically, what these medications can do is they can affect some of the contribution of inflammation or immunity to depression. Again, I appreciate not everyone has a background in neuroscience, but for those, again, who are less familiar, what we do know is that depression does not have a single cause. Depression has thousands of causes, just like what's the cause of obesity or what's the cause of heart disease. There's thousands of causes. And we also know that for some people with depression, they have something wrong with their immune system. In fact, many people, including our group, believes that the immune dysregulation is what actually led to them getting depressed. It predisposed that. In fact, the earlier slide that I showed you, that people with depression are more susceptible to contracting from ending up in hospital and dying from COVID-19, is an indirect substantiation of the hypothesis that there's something wrong with the immune system in people who have depression, and that's true. I put this slide in just to let you know that antidepressant medications are also given to COVID-19 patients who don't have a mental illness. So why would these clinicians be giving people who don't have a mental illness antidepressants while they have COVID-19? Why would they be doing such a thing? Again, our medications aren't targeting anything specific to depression. Among other things, they're targeting the immune system. And what's now been shown is that if people have COVID-19 and they end up in hospital because of COVID-19, in the absence of a mental illness, if they take an antidepressant, they're more likely to have a better outcome from their COVID-19. You've heard so much about new treatments like monoclonal antibodies, you've heard about steroids, you've heard about all these incredibly interesting medication. But I want you to know this, because wellness and depression is about having quality of life and function. We now believe that the reason why many people can't function at work and don't have much joie de vivre or quality of life is because they have a dysregulated immune system. And when the immune system is activated, they often complain of the inability to work. They often complain of the inability to work efficiently, and often have increases in absenteeism and presenteeism. So we're especially interested, in fact, in trying to target immune systems so that we can, in fact, improve their overall wellness. And for those who are wondering, why do people with depression have such high rates of overweight, obesity, and diabetes? In part, it's because of a disturbance in the immune system. Now, there's not one single cause of suicide in our society, and no person has ever committed suicide for one reason. So I really don't want anyone to believe for a moment that suicide has a simple explanation. It certainly does not. That being said, we do know that suicide rates are very sensitive to macroeconomics. In other words, when there's an abrupt and significant change in economic status, that has been shown at the population level to increase rates of suicide, especially in select populations. What we do know is in Canada and in the United States during the past 1 year so far, there's been a slight decrease in suicide across both countries during the past 1 year. Of course, we welcome that. It would be our conjecture that that slight decrease is in part because of some of the social programs and government programs that have reduced some of the insecurity during this time. That being said, some other countries around the world, for example, like Japan, are witnessing some of the highest rates of suicide they've seen in 30 years, especially, again, in young women. What's interesting is that the rise in suicide in young women in Japan was observed during the second half of the year of last year. During the first half of the year, suicide rates went down, a time when their companies and the government were supporting them. It's another indirect substantiation of the hypothesis that financial security can serve as a vaccination, so to speak, against suicide in the population. What we also know is that we talked about this, that access to care or utilization of certain services has been going up, mental health services. And if there's been one pivot that has certainly taken place in the last little while, the pivot, I would say, is towards obviously not just telehealth and telemedicine, but more self-directed care. In other words, patient-centric care and really patient-directed care. So it's not just patient-centric, it's patient-directed. And having the opportunity for internet-based treatments like CBT, cognitive behavioral therapy, has been scalable, cost-effective. In many ways, it reduces stigma because people are often embarrassed to go to a mental health care provider. So they don't need to have that embarrassment. They can access it at home. And what's interesting about internet-based psychosocial treatments for people experiencing stress, anxiety, and depression is that they are just as effective, it appears, as seeing a therapist in person, which is, of course, welcome because we just don't have enough therapists and we never will. So we need to have other ways to bring scale. It's been our experience for people who are off work, not just during COVID, but generally speaking, they benefit greatly, not only from the general emotional and psychological support, but functionally they improve greatly during this time. That is, during a time when they can combine psychosocial treatments with, in fact, medication if needed. Let me also, if I can, because people get on programs like this to walk away with maybe a resource or two, leave a resource with you. And if you get your pen and paper ready or your keyboard ready, it's the Depression and Bipolar Support Alliance, the dbsa.org, that offers peer support. And people who live with the conditions like depression, not the only mental illness, but it's the most common one in Canada, can often provide assistance to people who are affected. It's extremely difficult to compare apples and oranges, but there is a consensus, I think, that's growing that there is no event quite like this in our history books. We've had financial crisis, we've had clearly the Great Recession, the dot-com bubble in 2000, we had the Asian financial crisis, there's been the Hong Kong crisis, there was indeed of course, the Great Depression. And we look at previous pandemics, it's been really difficult to find something where the whole globe has witnessed GDP contraction the way we're seeing right now. A recent report from one of our articles, from one of our journals, has indicated that, if in fact COVID-19 infects you, there's about a third of a chance you're going to develop a depression or an anxiety condition. So I think what we're looking at post-COVID is a tsunami wave of mental illness and the needs for mental health services, which is going to greatly affect people's work. And as the back to work economy begins to ramp up again, I think there's going to be transitional stress, anxiety around that transition of going back to work. Now, just for your own interest, I wanted to share this with you. And again, we're not going to spend too much time on this, but you've all been hearing on the news in the evening, or wherever you gather your news, on the internet, what have you, that people may need boosters for the vaccine. And I guess we're going to find out. It seems like that might be the case, but I guess we'll find out. And the notion here is that the immune system needs to be rebooted, if you will, with maybe a booster later on. And maybe some people in society might require a booster earlier. Well, there's been a number of studies to show that if you have depression and you receive the chickenpox vaccine, the varicella-zoster vaccine, or the hepatitis C vaccine, or the measles vaccine, or the influenza vaccine, there's evidence to show, you'll find this interesting, that if you have depression, your immune response is not as robust. And that indirectly might suggest that people with depression will need more boosters. But what's also interesting is if you have depression and you take an antidepressant medication, what's really interesting is that if you take an antidepressant medication, what we know is that the immune response returns back to normal, which is really, really interesting. So it's important that people get the treatment that they require. It seems to have a boosting effect on their immune system. I thought you might find that interesting. I want to come back to this slide if I can. I didn't finish my point on that one. This was a study that indicated that if you've been infected with COVID-19, there's about a third of a chance that you're going to develop a mental illness. That was the gist of that. And this slide here, the point of this study is that antidepressants appear to decrease the risk of complications due to COVID-19. I'm not here, in fact, to say people should get antidepressants for COVID. I just want you folks to be aware that cognitive behavioral therapy, exercise therapy, mindfulness-based meditation, as well as medications share in common the feature that they improve immune responses. Let's now, if we can, talk a little bit in the remaining minutes, I'm going to stop, about long COVID syndrome. We're not sure what long COVID syndrome is. We don't even have a definition that we all agree on. What we do know is that about 10 to 40% of people have lingering symptoms that go on for several months, including fatigue, lethargy, cognitive impairment. And these folks can't work often, and they often complain of they just don't feel well. And we're trying to figure out what is going on here. There's certainly interest in understanding this more. There's hundreds of studies now taking place in the area, but I have no doubt about it that these people are going to struggle in the workplace post-COVID-19, and we'll just have to see, in fact, what is the best way to help manage these people. So what can we do about it? I'm going to finish with this slide. You can see here personal agency and collective agency. This is what's going to be critical. So our impact on the environment is personal agency, Collective agency is what we do as a society together. I think as a society together, what has been strong is the provision of financial support, small business support, financial forbearance, things of that nature. For personal agency, it goes back to the basics in terms of structuring your day, sleep, exercise, portion control on food, booze, and certainly social media, as well as interpersonal engagement in the pursuit of pleasurable activities. All that seems like pretty reasonable. No one's going to dispute that. But what's most important about doing that is it gives you a sense of control over your environment and does reduce the level of unpredictability of this time that we're in, which frankly is the most malignant aspect of this current situation. So COVID-19 has exacerbated the lack of equity in health. Also, it's exacerbated social determinants of health. We know that this has been an unprecedented time, but it's not a fait accompli that we are in fact given a sentence of misery. We can in fact preempt and prevent many of the unfortunate outcomes that are occurring by in fact imparting a sense of personal agency over our environment. I purposely want to keep my remarks brief to leave any time for Q&A that you might have, and I'm going to stop there. So thank you very much.
Thank you so much, Dr. McIntyre, for this very valuable information. We've collected a few questions so far, so if you don't mind, we'll kick it off with the Q&A session immediately. The first question is, how does chronic unpredicted stress differ from other types of stress, and what additional impacts does it inflict to individuals, especially in current work environments?
Great question. So when we in fact talk about stress, we tend to talk about stress as though it's a bad thing. Stress in fact can be a good thing if you're under stress before your examination, at college or university, or maybe before a job interview. The stress actually facilitates your performance. So in that sense, stress would be a good thing. And we perform better when we're under stress, actually, and we give our A game in that context. But what's a feature of that type of stress is that it's predictable. It's going to be over once the job interview's over or the exam's over, and it's typically very short in its duration. Chronic stress is stress that goes on for a long time, and certainly a year would be a long time by anybody's definition. And during chronic stress, what animals do, including us, is we adapt to the stress. That doesn't mean that we're off the hook. There's still maybe some consequences, but we have a sense of adaptability. And when we know when the finish line is, that actually has, to some degree, a mitigating effect on the hazards of stress. Chronic unpredictable stress in the laboratory is when the animal is not able to know or predict when the stress is going to end. And that scenario creates the most damage to the brain and the body of the animal. COVID-19 is an example of chronic unpredictable stress, in part because we just don't know when this is going to end, because the variants, etc. And that creates a double whammy. It's not just chronic stress, it's unpredictable chronic stress. And we know from research that that does the most damage to the brain's function and to body function. The brain likes predictability. The brain reacts with unpredictability in the same context with a more amplified response. This is why taking control, having personal agency, is not just a good thing to do. It actually tells your brain that you've got prediction, and that will decrease some of the hazards of chronic stress.
Thank you so much, Dr. McIntyre. The second question is, when we refer to PTSD resulting from the pandemic, what do we mean by that, and how does it translate in terms of an individual's mental health and other impacts?
Well, PTSD is a so-called stress-related disorder, and it's a disorder that is a consequence of the person has a perception that there's a threat to their well-being, their integrity, maybe in their life, and this certainly would meet that criteria. And people often have problems with their mood, their thinking. They often have terrible problems with their function. and are really paralyzed by catastrophic anxiety. It's a common problem, and it's increased during COVID. I think, in fact, it should be known that for many people, the trajectory is such that PTSD will quiet down after COVID-19, but not for everybody. It'll continue chronically, or some people may even have a delayed onset. It may come 6 to 9 months later. They didn't know they even had it. The good news is that there are, in fact, good treatments, psychosocial treatments, counseling treatments, and now medications that have been shown to be very, very effective for PTSD. So no doubt, this is going to increase well after COVID PTSD, and we're already being able to see that.
Thank you, Dr. McIntyre. And how have alcohol and drug use impacted those living with the depression during COVID, especially those people who take antidepressant and anxiety medication on top of drug use?
Good question. So alcohol decreases the function of the immune system. So alcohol consumption would suppress your immune response. So obviously that's not good for COVID-19. Secondly, alcohol in fact contains empty calorie, which increases the risk of obesity. Third, alcohol is a brain toxin. It decreases brain function, especially when consumed in excessive amounts. And finally, alcohol interferes with the function of psychiatric drugs. The government, for political reasons, has no choice but to keep alcohol stores open. They have no choice. So they're going to stay open. They call them essential services. They have politically, they have no choice. They have to keep it open. So I think, in fact, the message has to be portion control around alcohol. You've all heard it's gone up. In fact, the American Psychology Association reported just recently that 1 in 5 Americans have reported a significant increase in alcohol consumption. And what's interesting is that single parents with kids under the age of 10 report the biggest increase in alcohol consumption. No laughing matter, but you can imagine the distress that people are under.
Thank you so much. And has there, in terms of, you've mentioned rates of suicide, so has there been any sort of change with regards to rates of suicide, especially for those aged 10 to 29 years old, and whereby suicide is the second leading cause of death for this group?
You're exactly right. Here in Canada, there's 4,000 approximately suicides a year. In the United States, where everything's a function of tenfold greater, they have about 48,000 suicides a year. Around the world, suicide is the 10th leading cause of death, but it is the second leading cause of death in younger people, as you just defined it. We know that in Japan, in people under 30, women especially, suicide rates have skyrocketed during COVID-19. In Canada, we've seen a small decrease in suicide across the board in Canada. And we've seen a slight decrease in the United States as well. We welcome that, but I've not seen it broken down the way you just said. That is 29 years of age and younger. So we look forward to seeing it. I have not seen that age-adjusted data. I only have the non-age-adjusted data. But your question's a good one, because that's particularly interesting to look at, because we're hearing from many organizations that suicidality in our younger population has gone up.
Thank you, Dr. McIntyre. And so in that case, are you aware of any initiatives that have been taken by government or organizations to address the suicide pandemic?
Well, there's certainly been a number of programs. I can't speak at the provincial level because I don't know what's occurring outside Ontario with any confidence, but the federal government has a number of services. There was the student loans, there was the small business activity, there was the CERB, the financial assistance. Some might say, what's that got to do with suicide? Well, as I mentioned during the presentation, there's no single cause of suicide, and no one would ever believe that one cause could explain suicide. That's not true. But what I did say is that at the population level, suicide rates are sensitive to macroeconomic indicators. And so that's an important issue to bring up. And so when you provide economic security during a crisis, that decreases suicidality. We saw this in Scandinavia during the great financial crisis about 10, 12 years ago, that when those resources were put in place, it mitigated risk. So we'll wait and see. This is still a very fluid event, and there's a number of factors that we need to look at, and we need to follow this for the next 1 to 3 years to see where the trajectory goes.
And bringing it to the workplace, how can employers support their employees during the pandemic in terms of helping them cope with mental health challenges or illness, but also to help reduce stressors or factors that might lead to it?
There are 3 tactics that employers can do: small, medium, and large, private and public sectors. First, knowledge. We need to be aware this is a mental health crisis as much as it's a public health crisis, and I think that word is getting out, frankly. Secondly, I remember the old days where we used to have Friday afternoon gets together at the office, at the hospital. They used to have Friday afternoon. Often they'd have some beer and some snacks and this kind of thing, and a little social on a Friday afternoon just to kind of get the weekend started. That's not just enjoyable, but that was obviously a way to have collegiality. I'm not suggesting we pass out beer and potato chips. That's not my point. My point is that the Wall Street Journal reported on this just a few weeks ago, that companies in the United States are now introducing kind of social get-togethers, of course, respecting public health recommendations and all that, in the brick and mortar office, so people can kind of get to know their neighbor. And again, for many people, the work is not just a place to get a paycheck. It's their only place they have social connectedness, and that's an important aspect to foster. In other words, trying to introduce some degree of collegiality in the work environment and making a point of doing so. Thirdly, and finally, I think there needs to be accommodation and recognition that some people, in fact, are going to need to have more accommodation with working from home and various hybrid models and so on. I think that companies, frankly, have really been doing an amazing job at this. And we're hearing from leadership, CEOs of companies very much on board with this. With big companies, the Fortune 50, Fortune 500 companies and so on. And I think that's what needs to take place. And at the end of the day, I think that'll have a beneficial effect on brain capital.
Thank you so much. And then sometimes it's hard for employers to assess the level of stress and mental health struggles of employees, especially while working remotely. Do you have any recommendations on ways to make these types of assessment, and how do you recommend they open up the dialogue with their teams?
Well, I don't think it's the role of employers to be delving into the health of their staff, so I wouldn't be encouraging that. I think health, mental and physical health is a confidential matter unless someone wishes to disclose it. That's their right, of course. I don't see that as the role of employers. I think employers, as I said earlier, can do well by being aware of these aspects, certainly, in fact, introducing opportunities in the work environment for collegiality and connectedness, as well as accommodation. I think also, to the extent possible, an HR system that is trusted and known to be at arm's length from management and from direct reporting people. In other words, confidentiality preserved, job number one, to be able to direct people towards services, I think we can expect from employers.
Thank you so much. And in that direction, how do you suggest employers promote and support self-care during this time?
Well, I don't think that really employers need to invent a new wheel. I think there's lots written on self-care and wellness. And I think that to the extent possible, I think employers these days are more familiar with brain capital and human capital. And for people who are really thinking about what's best for your company or your organization or whatever the firm is, the employer is, I think we have learned during COVID-19 more than any other time how important brain capital is. And so to preserve brain capital, you want to invest in the training of your staff. We all agree on that, I think. You want your staff to be well educated and obviously trained appropriately. But you also want them to have access to wellness resources that are not just nice to do, but actually benefit their overall quality of life and function. So I see wellness and mental health investment by corporations not as charity work. I don't want companies to be charities. Companies should just earn a profit. I don't want companies to be my doctor. I want companies, in fact, to be investing in brain capital. And I think by doing that, they'll do a tremendous amount of service for their staff.
Thank you so much. And in the broader sense, what do we mean, or can you give us examples of practicing self-care and well-being?
Well, it's all the tactics you learned when you were a kid. You've got to structure your day. You've got to get up in the morning at the same time and go to bed at the same time. Now, so far that seems pretty basic, but that's extremely therapeutic. Secondly, there needs to be, in fact, exercise, and exercise on a regular basis. Yes, it's good for you, but it gives you a locus of control. Thirdly, there needs to be portion control on food and alcohol, but also on social media. In other words, you don't want to spend too much time drinking, eating, or spending time on social media. So far, I've said nothing brilliant so far. And then we talk about the importance of social engagement, of course, through the appropriate public health resources. So we all know what wellness is. That's not the question. The question really, how you can achieve it. The question, how can you motivate people to do it? And that's the challenge. And I think what we need to do is we need to, in fact, provide the appropriate incentives for people. And I think that there needs to be, from companies and organizations, the support put in place to foster that. So again, we've known for a long time these things. I've said nothing brilliant in the last 3 minutes, but we have to implement it. And that requires, obviously, the collective agency of our community and our government, but also the employment private sector.
So do you have any recommendations in terms of the incentives they could use, or how can they motivate people to adopt those lifestyles and practices?
Let me start off with what's the most powerful way to do it, but we're not going to do it, is to pay them. Now, people might say, what the hell is he talking about? Well, it's true. It turns out that the best way, the most robust way, the most reproducible way to change human behavior is to pay people. And I'm not suggesting that, I'm just saying this for your interest. In other words, we would be able to show that, you know, you can improve outcomes by people taking their treatment for depression or drug and alcohol abuse or reducing STDs, sexually transmitted diseases, by paying them. Now, we're not going to be passing out, checks and, cashier's checks to people. So, but the point is, this is modifiable. So you just need to find what, the salience, what's rewarding to the individual. And I think that, look, these are going to be personalized to everybody, but I think there needs to be rewards put in place. So you're asking what I think, that's what I think should take place. And there needs to be incentives put in place. There could be, everyone's going to be different. Financial is one, but there could be other non-financial rewards. Maybe, in fact, it's, you work a certain amount, you achieve certain objectives, you get extra time off or things of that nature. So the point is that these things are modifiable. That's just my point. But everyone's incentive salience is going to be different, what in fact really rewards them.
Thank you, Dr. McIntyre. We appreciate your insights. And then our next question is, do you think a positive, inclusive corporate culture is imperative to ensuring a psychologically safe workplace?
Well, I think so. I do think so. We've heard a lot about inclusion, equity, inclusion, diversity, and how important that is for a safe and high-functioning workforce. I happen to agree with that. I also agree that it seems to me, based on brain capital, the more diverse and equitable, how much equity there is, I think it's better for the organization. I think it's just a win-win. And so I do think so. I absolutely do. And I think companies should certainly prioritize that. Should not deprioritize merit, but should also, I think, prioritize equity, diversity, inclusion. Absolutely.
Thank you so much. And You've mentioned there might be a need to use boosters for immune systems in preparation for vaccination, especially in the case of depression and other mental health illnesses. When we talk about boosters, are we talking of chemical boosters only, or are there other type of boosters?
That's a fantastic question. I would take the view that there's boosters other than medication. I would, for example, I would hypothesize, but I don't know this, that exercise, excuse me, could significantly boost the immune response to COVID-19. That's an interesting question. I also think that engaging in mindfulness-based psychotherapy might boost the immune system in response to a vaccine. Those are testable hypotheses, by the way. I don't know that, but I would hypothesize that exercise and or mindfulness-based therapy would augment immune response to vaccines.
Thank you so much. And then, do you think there is anything that employers can do to help destigmatize mental health and break the stress cycles some employees may be experiencing due to the pandemic?
Well, look, that's a big question. Stigma against mental health has existed for thousands of years, so I don't want to give an answer that's so superficial and trite that companies can just do this and that stigma goes away. That would be silly. But what I would say is that let's in fact recognize that mental illness is a biological disturbance in your brain. And I think that word is getting out. There's something wrong with the brain function. And I think that's destigmatizing. It's not because they're lazy or weak-willed. That's important. And also, I would like to see the word issues eradicated when talking about mental health. I keep hearing people in the employer sector saying, I have a staff member who has mental health issues. I've never heard anyone ever say that the patient has cancer issues or diabetic issues or cardiac issues. And every time I hear someone use the word issues, it reminds me they're stigmatizing our patients. So let's in fact pay very close attention to some of these implicit biases.
Thank you so much. And then you talked about mental health repercussions post-COVID that we might not even be aware of that will happen. So what do you suggest for government workplaces and health sectors to do? What do you suggest for them to do to prepare for this kind of repercussions?
So I hope that in the fallout of COVID-19, the government at the federal level, of course, the provincial level has to implement it, really gives tremendous priority to mental health services of this country. So the Canadians who have a kid who's 10 years old or a brother of any age or a mother, whatever the case may be, who has a mental illness, they can get the psychiatric first aid right away because the treatments work. There's different types of treatments. There's talk therapies, there's counseling, there's medications if needed. There's a variety of team-based approaches. There's obviously digital approaches, but Canadians just can't access it. And I have heard for years from people how frustrated they are with the Canadian mental health system. And again, it doesn't have to be this way. And we have had some very good teachings and some very positives actually during COVID with some of the mental health services that have been provided. And during a time of COVID where we all agree it's been chronic unpredictable stress, suicide rates have gone down. Now that's not just because of government. There's much to that. There's, I'm sure, hundreds of variables at play there. But I would argue that there's some degree of provision by the government that's provided some help in that way, like, for example, reducing economic insecurity. So I think we need to have, I think that the best vaccine against mental illness is to have a job. I think we need to have job creation, job development, and job fostering. I'm a big fan of that. I think that gives self-efficacy and agency. I'm a big fan of people working. I think working is good for their mental health and good for their sense of dignity, because I think dignity is an important thing. And you don't get dignity if you're just getting money for nothing. And so people need to work. It's good for their mental health, good for their resiliency, good for their social engagement. and the government should really support that. I think we're recognizing how important brain capital is, and so really foster that so our Canadian population can really have the best chance to really flourish. And I think that's what we really need to see, along with psychiatric first aid services.
Those are great points. Thank you so much, Dr. McIntyre. And then,
by the way, these are great questions. If the next question is going to be, what's the meaning of life? I'm going to have to say I'm going to pass on that one. You guys are asking really complicated questions.
We're very grateful that you're still answering them and giving us great insights.
Okay.
So our audience agrees with you and have a problem with the word issues. One example is that they have adopted new language about suicide by saying died by suicide instead of rather than committed suicide. So what do you think is appropriate?
Oh, I think died by suicide. And I mean, we commit offenses, and when you commit suicide, it's got a negative connotation. And I agree that language matters. And that's a nice point that our colleague has raised. But I got to tell you, I cringe when I'm on so many different events and conferences and symposia and media, and people say, oh, mental health issues. That person has mental health issues. Really? Do they have cancer issues too? How about diabetes? So I think it's striking to me how people still have so much of a bias against people with mental illness. It's quite striking.
So what language do you recommend we use, Dr. McIntyre, instead of saying mental health issues?
They have a mental disorder.
Mental health disorder.
Mental disorder. And people say, oh, that's stigmatizing. No, it's not. No, it's not. It's, you say they have issues, that's stigmatizing. They're called mental disorders, and that's what they should be called. And they are suffering from a mental disorder. People try to pretty it up. I've been around this a long time. Oh, that person's had a compromise of their mental health. I mean, we don't need to speak like that. Again, that's infantilizing, it's stigmatizing. They have diabetes mellitus, we say it. They have obesity, we say it. They have cancer, we say it. They have major depressive disorder, we say it. And they are suffering from a serious medical disorder. And it shouldn't be infantilized. And I see this all the time, that patients are infantilized and they're stigmatized, and I see it in common jargon. And by the way, I see this on the 6 o'clock news, political leadership doing this, medical leadership doing this. So I'm just saying this is, there's systemic racism in our society, it's very obvious, and there's systemic biases against poor people, and there's systemic biases against the mentally ill. We keep seeing it, it comes out in this language, it's obvious.
Thank you so much, Dr. McIntyre, especially for answering those very broad and complex questions. We're receiving a lot of positive feedback about this great session. We're arriving at the end of our webinar. So if you have a last message to our audience, what would it be?
Well, my message is that chronic unpredictable stress can be chronic stress that we adapt to by incorporating some of the personal agency recommendations that I spoke to. Keep it simple, take control of what we're talking about. We can't control vaccines and viruses, but we can control our reaction to it. And guess what? Here's the news alert. It's going to be over. It will come to an end, and we look forward to it. I wish everyone very good health. Thank you for inviting me and sharing these thoughts with you. And I thank you all for your complicated questions.
Thank you so much, Dr. McIntyre. It was a pleasure. A few reminders to our audience. This presentation is recorded and will be posted for free on our website along with the slides. It will be also available as a free webinar course in our WWI eCampus. If you're a WWI VRA Canada or CPHR Alberta member, you receive free certificates of attendance. We greatly appreciate your input on our webinars as well as suggestions for future topic areas. All of our webinars are created for public access and supported by memberships and funding sponsors. Thank you again to our audience for tuning in, and we're thanking Dr. McIntyre for sharing his expertise. Have a wonderful day, everyone.